Hi, I'm Chris Kahn. I'm with UC San Diego, where I'm no one of importance. Um, and trying to stay that way. No. For the legal and regulatory group, some of the barriers that we discussed, the biggest one really is scope of practice within California, which I'm sure we're all familiar with, the Title 22 issue, the Health and Safety Code issue about paramedics only practicing at the scene of an emergency and en route to an acute care facility or at that facility. So that was definitely one issue. A second was talking about protection of vulnerable populations. Certainly something that we all have an interest in is making sure that we keep people safe. And we were, some of the things that we were, sort of discussing back and forth was that a lot of the folks that may be eligible for transport to, for example, alternative destinations, may be folks that can't necessarily consent right then and there and may need some extra protection. So from a legal standpoint, as well as an ethical standpoint, we need to make sure that that's something being addressed. EMTALA, I don't think you're actually allowed to talk about medicine and regulatory stuff without talking about EMTALA. We heard earlier in the Stanislaus County project, they ended up with an EMTALA issue, transporting people and having to transport people back and forth between between different campuses of the same licensed entity. And we discovered that it seems like EMTALA kind of gets its little fingers into everything. Consistent legal guidance is something that that we discussed as well. It seems that obviously there are plenty of laws and regulations affecting EMS, and I think there's generally good understanding of how things work. But for several things, if there is a very specific question, are we allowed to do X? It's not always clear who you ask. If you ask a few different people, you may get a few different answers. I remember asking, something came up in Orange County, and although the specific issue is probably not relevant here, it was like, hey, well, let's talk to CMS about it because it affects EMTALA. And the answer was, that's a really good question. Well, let's see what the courts decide. That was not something that I think any agency or person really wants to gamble on. Certainly liability concerns. It's possibly this is more financial as well, but we have to make sure that whatever we're doing is something that we're protected for, that it's clear that we are within our legal and regulatory framework, and that framework, if it's being modified to better suit the needs of our population, that the liability protection is being extended as well. And then effective versus unified advocacy. We were talking about all the different groups just here in California, not to mention nationwide, that have things to do with EMS advocacy, with speaking up on behalf of our agencies, our facilities, our patients, and there's quite a lot of them, but there's quite a lot of them. So one of the issues might be trying to find a better way to get things a bit more unified, to make sure that we're speaking with one loud voice that is clear, that is consistent, and hopefully hard to ignore. So some of the solutions we came up with, one is that nothing is going to change without a few issues, and one is we need to have data showing safety and efficacy of whatever alternatives we're proposing. Without that, no legislative change is even possible. It's just dead on arrival. And of course, that's going to go to data collection and that sort of thing. One issue that came up was possibly getting some definitions as to, can we be more flexible with how we do medical screening examinations? Do we have to take everyone to, a basic or comprehensive emergency medical services facility to get a medical screening examination by a physician? Can we use community paramedics for this? Can physicians do it via online medical control or via telemedicine? And getting some more flexibility in that may help us get around some of the larger EMTALA issues, because as we all know, that's an act of Congress to change it. So good luck with that. Obviously, we do need legislative change in the scope of practice. No, that one's pretty straightforward. One thing that might help that, however, is if there's a change to the national scope of practice model. So for something for NEMSAC and FICMs to consider might be that once we've sort of on a more national level determined these are things that really seem to work well, that people have had good success with, have a good safety margin, and is something that can be safely done by a certain level of provider, then it's consider including that as an option within the national scope of practice model for that level of provider, which might make it easier for the states to say, hey, look, the feds said we could do this. And then the other is just access to legal guidance with people who have subject matter expertise in EMS, because that can be difficult to find on some days. Any questions about the legal group before I hand this blasted thing off to someone else?
I only had one question. Did the one of the points raised earlier in the survey responses was issues about sort of liability related to quality improvement and sort of culture of safety stuff, risk management kind of issue. And I don't know if the topic of the Patient Safety Act and patient safety organizations came up in that group or not.
Not specifically. We and certainly I agree with you that implementing a culture, the culture of safety that I know we've necessarily been talked about extensively in some other fora, is something that I think will be of great benefit to EMS, but we didn't really talk about it too much in our group.
Well, we're certainly allowed to add things to the board, so if that's something you'd like to add.
Well, people don't. I know a lot of people in the don't know about it, but the Federal Patient Safety Act for states that don't have protection for peer review, quality assurance, quality improvement stuff, if you're part of a federally listed patient safety organization and follow, it's a little bit like HIPAA, where you find out the rules, you follow and manage the process that way, then your quality improvement process is not discoverable. Even your vendor's data isn't necessarily discoverable from that way. So from a liability and trying to kind of process improvement type standpoint, it's going to make a big difference over the next couple of years.
Thank you. I'm wondering if you can dig down a little further on the EMTALA issue. Without, I guess, spending too much time on it, is there a particular question or a particular barrier that is least conducive to innovation, or that is sort of the biggest barrier when it comes to the enforcement of that act that could be overcome, or that you need a legal opinion on, or something like that, besides just saying this law is a real problem?
So I'll just say this law is a real problem. The impression that I got from the rest of the group, and please everyone who's there speak up if I'm butchering this somehow, is that a lot of it had to do with the medical screening examination requirement. It kicks in at different points for different people in different places. Sometimes if you have a hospital-based ambulance, it kicks in when you're either in the ambulance or within 300 feet of the ambulance, or basically however because it's just you present requesting a medical screening examination, but that definition of when you present varies a lot, and it's not always interpreted in the same way in different CMS regions. So having more consistent guidance on who can perform the MSE, where the MSE can be performed, I think that would be helpful. I'm not sure, honestly, if we want to get into necessarily the components of an MSE, because that's probably going to end up being way too prescriptive, and we're going to shoot ourselves not just in the feet, but in probably every other body part. But I think certainly knowing if we can have paramedics assist us with the MSE in the field, even if it's with direct online physician oversight, I think having that clarification might be helpful. Any other comments from the legal and regulatory group on that?
I don't understand the purpose of having a paramedic prescribe a medical screening exam in the field. Medical screening exam is an EMTALA mandate, and it's a responsibility of the hospital. So if the patient is still in the field, they're not yet the responsibility of a hospital, and there's no EMTALA mandate for a medical screening exam to be performed yet. Unless it's a hospital-based ambulance, which doesn't exist in California, to my knowledge. Or it does? Okay. North of San Francisco doesn't count as California.
Is that actually a fact? Because I know hospitals own urgent care centers, and those urgent care centers are not subject to EMTALA. Hospitals own lots of things. Our hospital owns a real estate tower.
That would count as a hospital. That's an urgent care center.
The urgent care center does not.
It may or may not, depending on whether
There's no
that is
freestanding
a distance.
ERs in California.
What's that?
There's no freestanding
Sorry,
ERs in
no
California.
freestanding
Except for one.
I think the issue that came up in our group, the case study, was where the alternate destination was also owned by the same health system as the hospital. And so you needed to do a medical screening evaluation at the alternate destination. And I think that was the issue. If they hadn't been integrated, if they'd been separate entities, maybe you wouldn't have had this EMTALA issue. But in a way, the issue is, if integration is supposed to help us to align incentives, here's one area where integration actually is getting in the way, or EMTALA is getting in the way despite the integration.
I guess I still don't understand. Sorry, I try not to monopolize this, Kevin. So, but if the patient is transported to either the urgent care, wherever the site is that has the EMTALA mandate, then the medical screening exam can occur there. The only time it might be of benefit to perform it in the field is if you're never going to transport the patient to an EMTALA mandated facility. But in that case, there never is an EMTALA mandate. So that's the way I interpret the regulations. I'm not sure how other people interpret it.
So as they do on CNN, we're going to have to leave it there. So we're going to move to the next group, education.
Hello, thank you for having me. My name is Drew Bessent. I feel I'm going to be excellent for the educational area because I'm the least educated man in this room. So I was chosen. They pointed to me. We talked a lot in our group about education as well as culture. We were blended, two groups together. A lot of back and forth, not a lot on the board, but I'll just kind of go through real quick kind of some of the things we had to say. If you have any questions, I'll just look to my group and they can answer them for you. Education, we went over what level of education is appropriate for a community paramedic. Kind of, do we need to have anything higher than where we're at? Is a bachelor's degree good? Associate's fine? Should there be some changes? Talked about that a little bit. Another issue is who pays for this training. Is it the individual groups that we work for, fire departments, other stakeholders? Who's gonna cover those costs? And then how do you obtain buy-in from the group of people that are actually doing it? Those are the kind of hurdles we were hitting, and these are some of the solutions that we came up with, which I think are the best out of all groups. Number one, having medical director training that would create unified oversight. That's one thing thrown out there. And being not a medical director, I don't know what your formal training is, but it sounds like a cool thing if you're on the same page. Yes, ma'am?
No, it's zero training in a medical director in most EMSs.
Okay.
Have to be an MD.
Awesome. So I think I know what job I'm going to do next. Medical director. I'm perfect. Perfect for that. Point number.
About that was the fact that the knowledge and skill set of EMS medical director and a community paramedicine medical director are significantly different. And learning things about chronic care management, about geriatric care are really key, I think, in being an effective community paramedicine medical director. And I think having a single medical director that has that more comprehensive skill set is a better option than having parceling out medical direction for cardiac patients, for stroke patients, for frail elderly patients, et cetera, is probably what we would advocate.
And we'll hold other questions till we get through at least presented.
Thank you. Having a longer clinical component for community paramedicine. We have some when you go to paramedic school in general, and then as a community paramedic, the training we did was pretty quick, and that was the most beneficial part is when you get out in the field, you see people start actually putting stuff into practice, not just seeing it on a screen or talking about it with the teacher in a breakout session, then actually seeing it in the field, which is awesome because we got such a good program down in San Diego City that we can go see, but more extensive time with that would be beneficial for everybody. Next one, creating a specialized national curriculum that creates a more specialized positions. It would encourage a deeper buy-in from firefighters or other community paramedics and other stakeholders and increase our level of validation. Next one, capture our training hours on duty to translate into educational hours or units towards completing further education. We do a lot of in-house training in the fire service and in our jobs every day that we don't really get credit for, other than we got to do them. And we're just punching the hours to get them done and learn further our own knowledge and be better employees. But it'd be cool if it started to go towards education, towards an AA, bachelor's degree for those of us who don't have them. Almost the end here, raise the bar. One of the things we want to do is in our education process with our groups, one of the hurdles we thought, instead of working from the top, like finding the best upper echelon guys in your department and teaching them how to be even better, really getting every level, the guys from the bottom to the middle to the top, at the same page, or just working from the bottom up, kind of changing the mentality of how you're teaching or where you're starting to teach your employees. And finally, integrate patient follow-up into education, as well as educating hospitals and urgent cares the benefit of the knowledge of patient outcome. A lot of times, probably every day, we go on calls, we take somebody to the hospital, we do interventions, and we have no idea where it goes from there. We drop them off, handshake, a high five, a hug, and then we never hear from them again. And when we do want to know about anything that happens, it's really difficult to find it out. Call the hospital, you go in on the next transport, they've moved, you hear, oh, I think they're doing okay, but it would be definitely beneficial for us to hear, what happens to that patient. And as far as our education level, it would help us out dramatically. And if that wasn't said as eloquently as ever, I'm sorry. You can talk to my group, and I would love to field any questions you have.
Here in California, the state schools, meaning the University of California, as well as the state universities like San Diego State Universities, recently collaborated with the community colleges to start to develop four-year degrees in disciplines that are not being offered at either of the former two. And for the first time, a school in, I think, upstate California, in Northern California, was selected to give a four-year degree in EMS. And I would have loved it if it had been one of our own in San Diego County, but that turned out not to be the case. But the community colleges are starting to give baccalaureate degrees, in other words, in EMS. Now, what's the benefit to doing that? And I think that's got to really get fleshed out. For one thing, the salary rate is probably higher, I would think, if you went to a four-year school and you had a bachelor's degree. When you go to London and you talk to the guys over there, they start a little earlier, but they all have a four-year degree, and there's a progressive sort of a structure to the curriculum. And I do think personally that there's a challenge inherent to people in the healthcare industry, that those people who have less training tend to be thought differently than those people who have done, like Alex Gillespie, who did 12 years of neurosurgery or whatever the heck it is. It's just inevitable. Did you guys explore this issue about the validation within the House of Medicine for a degree program that basically provides somebody with a little bit more than, just an EMT training? Traditional, which is abbreviated today, and obviously not even an associate degree.
Anyone from the group want to address that?
Why would anybody go to the four-year school if they could just go get to community college?
So,
I was not.
do you want to answer?
I wasn't part of the group, but I'll comment on it. So one of the questions, of course, is, and I think to bat around throughout California, is for new entry-level paramedics, do we increase the prerequisites to be more harmonious with the nursing program, such as having anatomy and physiology as a minimum requirement? Do we start to create bachelor degree programs that include cultural competency as a minimum, greater documentation, and for those people that are bachelor degree prepared, do we have our two at least recognized programs right now, critical care paramedic and now the pilot community paramedic as part of that curriculum, to include maybe management and or clinical leadership or research? I mean, I think these are questions that need to be on the on our dialogue in California. So, so as we move forward with education, if we want to be more innovative, we have to create more innovative leaders, I think.
Could I just add on one more piece of mine?
Yeah, but let me just at least answer what the group did and did not discuss. The group, yeah, and please correct me if I'm not summarizing correctly. There was a lot of discussion about whether there was a need to achieve those things for internal purposes, or whether there was an external perception and educate, as sort of you said, Jim, you know, improving our perception in the House of Medicine with some of these things. And so there was discussion about it, but it ultimately was not something that the group decided to place on the board in terms of we couldn't come to a consensus whether you needed to have a certain level credential. So, but you know, it is open for the entire group to add things to the board that you feel ought to be at least voted upon. We're all going to get a chance to vote on these. So if if people do agree, don't agree, just don't put you don't put your vote on that item. So while try to formulate what you said into sort of a recommendation.
The other thing that I see as the city medical director is, unfortunately, the majority of the candidates who come out of EMT training these days are not ready to start working. They have to be completely retrained. And so we spend a lot of money and a lot of time at San Diego Fire and EMS and Rural Metro to take somebody who comes out with a certificate of competency from a community college and then teach them how to be a EMT, because they're really not ready. And so we have this entire workforce of people, and not only that, but we have a large number of people that are being pumped out of the system that are making a huge impact on the people that are responsible to train them. So we've essentially created a system where everybody's got to be a paramedic, is what it comes down to. And I'm certain that leads naturally to how do you measure the competency of the individual, and how do you sustain this educational campaign to kind of keep people up, when frankly some people just want to be firefighters and they're only going to get a 5% pay rate, and they've got to be a paramedic, because the system today, especially if you have an ALS first responder system, is that the paramedic is the part of the job that people don't want to do. And I'm not saying that that's true for everybody, but if we're going to talk about EMS and innovation and challenges, one of my biggest challenges is really trying to be able to identify that people are actually competent in what they're supposed to do in the life-saving side. In addition to all this new stuff, how do you incentivize somebody who is also at the bottom of the pay grade? And I hope we get to that in finance, but when you're being paid $12 an hour and you're expecting somebody with a master's level thinking, it's just a mismatch. And so the economy of the entire thing starts to fall apart at some point when you think you can get, kind of the barefoot doctor concept of somebody who's working for the lowest pay scale in the healthcare system. That just doesn't completely fit. And I think we have to rectify that somehow with incentives in education.
I like the idea of heightened training. I also think, though, that in other areas of the healthcare system, where we're thinking about how do we, shift to lower cost, improved overall quality of care, there's also a need sort of at the top end for physicians to be more willing to do sort of a soup to nuts type approach, so that you're not constantly handing people off. So, I almost wonder too, sort of in combination with this idea of perhaps heightened training, but maybe also combining it with some kind of managerial structure where there's supervision by somebody who might have a higher level of training. You know, it could be, you know, an APRN or a PA, I don't know, you know, can think about that. But, you know, in home health anyway, there's a lot of talk about better use of home health aides as being sort of a primary point of contact. But there must be, doing a lot more that might be clinical, you know, fed into the more clinical side instead of just the skilled, you know, unskilled or, you know, lower skilled side of care. And then having a nurse, you know, better direct what should be done next so that there's, you know, sort of a synergistic approach. And then usually that's linked up with some kind of technology. It could be just phone calls. It could be telemedicine. It could be Skype. I mean, many different forms to leverage the workforce.
Great, thank you. Is there anything I should be adding to this list for the voting session? That I heard anatomy and physiology.
I would actually propose, if you're going to add something to the list, that you frame it in such a way as begin a dialogue about regarding curriculum for bachelor's degree programs in EMS.
Do I have a second or something? A comment or a second?
Yeah, no, something to potentially add. I've encountered 3.
We have to keep it brief because we're getting way out of time here.
I've encountered 3 EMS training curricula or programs at community colleges and whatnot around the country that have looked at the data collection side as endemic to their training. They actually have said they wanted to go so far as to use EPCR in their courses to be able to get people used to documenting like that. And I just wonder if, since we're there, again, there's been so much talk today about what data collection means and how you do it and whether or not you understand the statistics on the back end, wondering if that might be part of the practicum, essentially, of saying get used to writing down good data and capturing good data, demanding missing information so that you can close the gap on the other side.
All right, I'm going to...
Very brief.
Okay.
So just so we're learning from the rest of the healthcare ecosystem, they're doing team training. So I would recommend, whether we're looking at associate degree programs or bachelor's degree programs, that we incorporate into that interdisciplinary teamwork and team training.
All right. So I'm going to go a little bit out of order. We're going to start with number 3. So something that we came up with, we're going to go out of order here because we feel like in this whole project, we've gone out of order. And we've kind of put the cart... Right. No problem. But we put the cart before the horse a little bit in that instead of going to the consumer, which is the payers, and asking what they want, we've come up with all these little projects. And like Field of Dreams, we believe if we build it, they will come. But we don't know that anybody really wants all of these products that we're producing. And so in order to have a financially viable product, our idea is we need to go to the payers and find out what their needs are and what they want out of community paramedicine, and then we can build that for them. And this might be management of super users, which we've discussed, which are costing a lot of money to payers, because we have some strategies for dealing with that. This might be avoiding hospitalizations or avoiding emergency department visits or readmissions. Or this might be public health interventions, which might appeal to private payers, but also to public payers, such as counties, which have a public health responsibility. So that was out of order, number 3. The next step is we've got to get the payers to the table. We have a lot of very influential people here from medicine, from EMS, from technology. We don't have influential people here from the payers. And so we need to get them into this room. I think we have enough influential people here that they would want to hear what we have to say. These might be health plans. What was that, Alan?
Yeah, Kaiser who?
We have, Jay doesn't want to admit that.
We're talking about influential people.
So we've got health plans. You know, we'd like to see people from CMS. people from county boards of supervisors and other governmental agencies that are responsible for public health. And then additionally, somebody from our group mentioned there might be a role for concierge programs where individual patients might want to pay a premium either on a fee-for-service basis or on a monthly or yearly basis in order to get a higher level of EMS response where we have them come out to their house to do things that are outside of the scope of what EMS usually does. When we do this, we need to have more than one payer at the table. So we ideally would like to have all of the payers covering lives in an area, or at least most of them, in order for this to be effective. Coming down to 4, and 4 is split up into 2. So we have a question, which is community paramedicine a new product line that should be developed separate from EMS, or is EMS just something we've got there anyways, and community paramedicine is whatever we can do with the extra efficiency we can squeeze out of excess EMS capacity when they're not running calls. And we feel like this is the old and broken model from 2 months ago, and this is the new hot, sexy model from today. And this is really what we need going forward, is to realize that for this to be successful, we need to have dedicated community paramedics that are spending all their time on this. They're not going to be distracted by the multiple gunshot wound, shooting, train derailment that's 2 miles away. There was some amount of discussion. Not everybody in our group agreed on this, but the consensus is this is the model we should use moving forward. And then, so those are our 5. And then when we're looking for solutions, kind of the one low-hanging fruit for a product we think that we really could sell to payers right now, which would actually be very easy and we could integrate into EMS programs, is that managed care organizations do have an interest in having patients who access care through the 911 system transported directly to their medical home hospital, which often is not done because the providers don't want to go another 15 minutes or 15 miles because that's extra cost to the provider. But if there was money for the provider to go that extra distance, literally, to take the patients back to their medical home, this would be a benefit to the providers because they would get paid. It'd be a benefit to the payers because they would have lower cost care at their medical home hospitals, and a benefit to the patients because they're going where they're going to get continuity of care. So this seemed like a project that would be relatively easy to do, require little resources. So steal that idea. Good job.
Fantastic. Thank you, Ben. Any comments or questions for the group?
I think you've spoken to what is truly a conundrum, at least with the biggest payer, and that's the Fed's CMS. You know, the CMS innovation grants, one of the criteria for their success was to be that that program demonstrated value, it was reproducible, sustainable, and scalable, and then they would pay for it by changing federal health policy to push money at it. Well, they didn't explain how did you get from the single pilot project to the multi-site, scalable, measurable, demonstratable, good value product that CMS would buy. So that, you know, you're talking about that's the goal, but there's no real clear pathway about how you get from A to XX, you know, to make that happen.
Any other comments?
Hey.
All right, we're moving right along. All right, somebody from the data and technology group. Have we solved all the interoperability issues?
Yeah.
Well, the group had some quite spirited discussions about health information technology and data. And we looked at various barriers to this. I think we had lots and lots of pages up on the wall, but I think these are the summary pieces. Number one, I think there was a lack of knowledge within the EMS system that we actually understand what data and health information technology is today. And so consequently, our recommendation number one was to create a shared vision, a shared educational program so that everybody can begin to understand what the capabilities and capacities of health information exchange and health information technology is today. The second issue that we had quite some discussion about is a lack of standardization between health information systems. The inability from one, let's say, electronic patient care record to talk to another electronic patient care record, even within individual systems. And so consequently, I think our number two recommendation was that we should really create an environment where we can enforce interoperability standards, such as those brought forward by NEMSIS, the NEMSIS 3.4 program, which utilizes the HL7 language to be able to communicate from field to hospital. The third area that we identified is realistically a lack of performance measurement in EMS, that there's no national standards. We're unable to really get outcome measurements from the hospitals for whatever reasons. We had lots of discussions about what those reasons might be. But I think at the conclusion, we decided that probably the only way to move forward with some sort of performance measurement program for quality improvement and population health in California is to require performance reporting by both EMS providers as well as hospitals, and to ensure that outcome measurements can then be collected and evaluated at that point. The fourth area was an understanding that some of the barriers may be workload, and that manual structures are expensive to maintain. And so that really the answer is that we need to create some type of an infrastructure that begins at the provider level with electronic patient care records in order to move electronic patient information to the hospital. And really the idea is that ultimately we would build a health information exchange infrastructure to facilitate a longitudinal patient record. This longitudinal patient record will obviously help in better transitions of care, improve clinical decision making at the scene, improve clinical decision support services at the hospital as well too. Next, I think we understood that we need to prove our worth, that EMS needs to prove our worth, and that the only way to do that, to show value, is to develop pilot projects to demonstrate kind of this proof of concept and to really show how better patient care will result as a result of better health information technology, and how we can improve population health, i.e. Performance measures through the evaluation at the local level. Ultimately, I think we all understand that real-time rapid cycle improvement is important. We understand that culture and workflow is not going to be easy, but ultimately by having a better vision for health information technology, we can move California forward in this area.
Those are fantastic. I want to make a comment I forgot to make on the finance in regard to get the health payers at the table. We do have a health plan on the National Steering Committee, and I know our federal partners are working really hard to get us some CMS representatives at the DC meeting. So at least they'll be part of the conversation in the overall project. And I had a question to start off, was who would be the one to require the reporting on the performance measures?
Oh, we had a long discussion about that. Really, we think that ultimately it's got to be a state law. I mean, a state law and or regulation to require hospitals to actually report outcome data. But we understand that we're going to have to, in order to get that law passed, we have to describe to them what the overriding value is as it relates to quality improvement, population health, perhaps improved patient experience, and lower cost to them.
How about Joint Commission? Can we get them to do it?
Kevin, I can't miss this opportunity to put a plug in here for the NASEMSO process on graciously funded by NHTSA for the development of EMS performance measures. That process right now is actively soliciting suggested measures from the EMS community. EMScompass.org will take you to the to an opportunity for making that. Please don't miss this opportunity. There's plenty of smart people who could develop them for you, but you will be happier with life if you can see your own shadow in that process. But I agree with you. And the process of requiring the outcomes from hospital stays is going to be integral in this, so we're not doing more measures like IV starts, but rather things which show the conduct of the patient's care. What was the trajectory of the patient's care? We can only do that recognizing we're part of the healthcare system.
And one of the things a few years ago, actually looking at cardiac arrest survival was a kind of a classic tracer condition for EMS outcomes, which are currently deficient. And you're probably familiar that we've got a very strong ally in the American Heart Association who's already published a position paper at least 3 or 4 years ago, said that there should be national outcomes reports and that communities should know their survival from cardiac arrest. So again, this concept of the volunteerism, which is the way the CARES registry currently works, as opposed to having some statewide requirement. The beautiful long-term goal would be to actually build this into the government's Healthy People measures. Healthy People 2020 says we want to improve the number of people who do CPR. We want to improve the number, but they don't have anything about the number of people who are going to live. And so we need to sort of up the ante a little bit at the federal level to also build in those performance metrics of the federal government to incorporate more contemporary EMS measures.
I just want to put a quick pitch in to reframe the performance measure conversation, and you hinted towards it, from a patient-centered perspective. I don't think we need hospital measures. I don't think we need EMS measures. We need patient-centered measures. If somebody has chest pain and they call 911, the primary PSAP, the secondary PSAP, the call taker, the first responding fire service, the transporting agency, the emergency department, the cath lab, from the patient's perspective, their result depends on a really integrated system. And until we start to build measures that measure from the patient's perspective the integrated system, we're going to continue perpetuating we helped, and I want to show where you end up in that which outcome do you measure conversation. Well, from a patient's perspective, and cardiac arrest is one that's really up in our community. We've started a monthly survivors meeting. We got 65 cardiac arrest survivors that are meeting every once a month. And one of the things we're learning is that the cognitive support for people who've survived cardiac arrest doesn't get implemented nearly early enough. So we've got some people who are being discharged alive who can't remember third grade, but could if they had some therapy and help earlier. So really, truly looking at things from a patient-centered perspective, I think is an important kind of value for us to have as we drive all of this.
Just one other point that came up that sort of sits between the questions of enforcement and building an infrastructure and finance is the question of whether it's called what I call it, which would be procurement reform, or you call it something simpler like being able to get what you want. The topic came up of basically once you've established what you're trying to get, we still need to sort of open or shed sunshine on, or whatever the appropriate analogy would be, to be able to get the products and services that are needed in order to make these happen. And given contract terms versus the speed of technology, for example, in RFP processes that can just take forever and then have to go back through cycle after cycle, some mechanism to help, whether it's at a state level or at an individual agency level, the folks and the stakeholders to get the products and services that they want, so that they can do the enforcement, stay on the standards, and move the infrastructure forward a lot more seamlessly, so we don't get out of sync with the marketplace.
All right. I think we'll move on to the last section, unless there's any burning comments about that. Could we have somebody from the culture group present those findings? And now I'm just going to give you a preview of what's coming. During this last section, Hugh's going to start distributing some sheets with dots. And what did we decide on? 10 each? You're all going to get 10 dots, and you're going to vote. I'll tell you a little more about the voting, but start to think in your mind about what are your highest priority action items that we can do here locally in California and get things done.
All right. So regarding culture, we identified culture on different levels, and one was just the general workforce, our profession. Was it in our culture to accept community paramedicine? And we kind of discussed it briefly. We had very little time because we also did this one, so we spent probably about 5 minutes on this one. So we also discussed culture in our community paramedic teams. And actually, let me start out of order for continuity. We'll start with the first thing. As a profession, we felt that we needed to embrace the scientific method, which there's been some discussion about. So that's on a professional level. On a provider level, we had a number of things. And one was we felt that we needed to shift from a less prescriptive approach in medicine to something that was more like a public health approach. So if you can imagine dealing with social vulnerability, say Lou gets drunk, he's plastered all the time, and I come up and I fire off 20 questions. Huh? What's that? And I fire 20 questions off at him, and I expect him to answer them right away, and then I say, okay, I know what's wrong with you. You need to stop drinking. This is not an approach that's really going to work. So we really need to embrace new techniques. We need to look at motivational interviewing. We need to understand that people usually trust themselves the most, so we have to guide them through that internal dialogue to change their mind and truly motivate them. Among our teams, we are shifting from a reactive workflow to a proactive workflow. So how do you take people who it's been acceptable to sit on your bed, like we said earlier, sit in your bunk room and listen to your headphones and read a book in your downtime, where you have to shift from to managing your own workflow. So you have to drive productivity, and how do you help a culture? How do you help establish a culture of that? And one of the solutions was that you have to provide them with autonomy. There's no way around it. They have to be out there being able to do what they do, but to provide boundaries, very specific boundaries and measures to them. And as long as they function within those, they can perform their functions as needed. And then we also did talk about how you have to teach culture from the top down. If you're not actively working to define a culture, it's going to define you. So you really need to start at the top.
Great, thank you. I think in this last one, we're also talking about just culture, right? We're talking about not being punitive or something like that. Just culture. We're talking about a culture of safety, and that's okay. All right. All right, any comments, any questions? Are there anything missing from any of these lists? Jim, you got a hand up?
Yeah, I think, it's not my issue of culture, but I think we'd be ignoring an elephant in the room if we didn't say that there are culture clashes here, and that there are some entities that really feel that this is not healthcare that we're doing. This is, public safety that we're doing. And so I think on some level there's got to be a kind of a harmonization of this, what are we doing when we're taking care of patients in these various mixed capacities. And I know that there's got to be a way to get to the answer to that, but I've had people say that, you know, community paramedicine is not healthcare, that it's public safety or it's public health, but it's not healthcare. And I don't know what that even means, other than to say that if you can do healthcare in a hospital, in a clinic, in an ambulance, you can do it all over, but it's healthcare. And it should abide by, in my opinion, you know, it has to stay within the boundaries of what everybody else thinks is healthcare too. And I don't know, I just think that that's going to be an issue, because I know that there are different unions that have very different takes on this. So I'm just throwing it on the board as inevitably it's going to be a conflict that's going to have to be worked on.
Yeah, I was going to add, is for something I feel like might be missing is along the lines of what Jim is saying is, and this might be public health as well, is we didn't talk about the innovation of prevention or doing anything to prevent a lot of what we're trying to take care of here, which is part of the healthcare spectrum. And whether it's our job or not, I'm not sure, but it could be an innovative idea, because it certainly would save lives and save money. The other concept that we didn't really talk about is that when we're talking about doing innovation, you know, if we're a company, if we consider ourselves a company and you're going to do innovation, you have an R&D department. For different agencies to continue to try to beat their heads against the wall and learning how to try something is difficult. So I think we, as part of this, maybe need an organization or certain areas and pockets of R&D. And either an organization that helps other areas do this R&D or does the R&D themselves, because you get better at it over time. And I think that would make things go a lot quicker, and also would allow us to collect the appropriate data to show the return on investment, which you spoke about in certain ways amongst all these entities here. If you show ROI, people start paying for it.
Jim, on your point, is there a recommendation that we should put up on the board for harmonization? But what do you think about that while you hear another comment?
So, I mean, from a culture perspective, it reminds me of when I started in EMS, and I started in a public utility model system where we ran all EMS, all emergency and non-emergency, and scheduled calls for the whole community. And from that point, you know, you really had to hire a different kind of person than somebody who just ran emergency calls. And it seems in many ways very similar to, you know, we had to intentionally, you know, almost try to scare away people that were just there for the lights and sirens. There were people that were just there for that kind of work. And I think that if whether it's nationwide or whether it's in one small community, you know, the idea of who you hire and what their expectations are from the beginning is just a key part of this, because we've got, you know, generations of people that we might never shift gears, but the longer we wait to only hire the people that are going to be good in that role or likely to be good in that role, I think will be a problem. We'll always be trying to change our staff rather than hire staff that are amenable to that change. And just I've said FISDAP a couple of times, and I have no business with them in any way other than I'm impressed with them. But they work with a lot of community colleges and other EMS educational institutions, and do a lot of you know, for lack of a better term, this probably isn't the right term, but sort of personality testing and assessment, and then follow those staff members, those EMTs and paramedics through their career, working with the agencies that they go to try to identify who's a good fit or not. And I think that fits in this model. I think it also fits in a lot of the discussion going on about PTSD and provider suicide and wellness and things like that as well. Who's suited for this better than others? It's just a thought.
So is there a recommendation there, like recruit based on...
Hire for culture.
Any other comments?
Kevin, the only thing I see that's missing from there is that much like the emergency physicians that we've been talking to, who, you know, only see the patient in the emergency room, take care of them, and then they're gone. They don't, you know, there's no continuum of care for them. I think that EMS needs to start seeing themselves culturally as part of the continuum of care, and not just part of that emergency response, transport, drop off, don't know anything anymore. So culturally, they need to see themselves as a piece of the whole entire pie. No pun intended.
Yeah, at least within our group, it seemed like they were trying to. There was definitely that interest. In fact, I think they listed, wanting to get follow-up care as part of incorporate that into routine education. So I was represented, but and in fact, the issue was like, how do we teach other types of providers to include us in that continuum of care? I don't know what this solution is there, but
You can't get it right now if you want it.
Right.
I mean, yeah, there's so many boundaries in the way. From my experience, that was something that I've always been interested in. And the problem is that you drop someone off at the hospital, whether it's an acute status patient, mild status patient. If you wanted to learn from that call, speak with the physician, get some continuing education, there's boundaries to that. The patient may already be admitted, the physician may be busy. If you didn't respond or if you didn't take someone back to that hospital, it's almost impossible to get a follow-up, because if you call the hospital and you talk to the nurse, they're going to tell you that they can't tell you anything. So they're like, well, there's HIPAA laws against that, and it's like, well, I was part of the care plan, but they have that assumption, and that's especially true with pediatrics. So yeah, good luck trying to get a follow-up on a pediatric.
I think the best recommendation is already up there to address this, and that is to what you said earlier, was how do we figure out a way from the get-go to, as all the different professions come up, how do we do this team training thing so that they don't forget the other piece of the team when they're further on in their careers. All right, any other, lots of comments, okay.
I just wanted to add to what the gentleman behind me had mentioned about education, that we really need to include that component. It's not just provider education, it's also education for the patients. So it's patient education, because if this is the only access to healthcare that this patient is going to have to this community paramedic, then they have to be the educators on how to access the system appropriately. And they just need to add that piece, because we have all this influx of people with insurance and they've never had insurance before, and they may not know how to access. They've got it. I mean, it was a pretty complex process for them to just apply, right, and register. Look how complex that was. So I think we really need to add, and that would be my recommendation, to add something for patient education. I think if you're talking about access to the system and we're talking about community paramedics, I think the community paramedic himself has to be the educator on how to access the system appropriately. He would have to be educated as well. They would have to be educated as well.
Just help me out where I should do that.
Under education, I don't see anywhere else on there that it would apply, but if you have an education component, you would have to have provider education as well as patient education.
Thank you. This has been an incredible discussion and a lot of fun for me anyway. I want to encourage us, I don't know if this would really add anything to the 5 sheets we have up already, but I want to encourage us to think small in addition to thinking big. Fantastic discussion about community paramedicine and the future of the profession, and some really big picture stuff. I want us to be thinking about what is helpful on an everyday level too in the system we have today, and if there are small changes we can make, if there's a culture of innovation that we can create that would allow for small changes in addition to big picture changes like we've been talking about today. And that might just be as simple as adding to the culture section to constantly question how we do everything, whether it's clinical, operational, financial, or educational, legal, or otherwise. But a lot of the innovations that are taking place is not creating a huge new service line or spending 200 hours teaching a paramedic to be a community paramedic. It's really small stuff that we don't really talk about, but if things were just a little bit easier, it might be able to make a much bigger difference. So I don't know if there's anything to add or if anybody wants to react to that, but I wanted to make sure that was part of the conversation.
Yeah, absolutely. Thank you so much. I mean, when you vote, it should really be things that are actionable, things that we can all take from this meeting. I think, if you don't mind, he was waiting first.
Since I guess we're going to do some multi-voting, I just wanted to clarify one of the points in our cultural discussion that Brad brought up, and that is that we absolutely have to be a culture that is willing and able to prove that what we do is safe and adds value. That we can't just tell people what we're doing is great, but we have to prove it, and we have to prove it scientifically.
I'd like to propose to add something to the finance sheet. And I definitely think you should be talking to payers, but I just want to encourage you to be talking to other providers, like home health providers, there might be an opportunity for contracting or partnership, particularly in the context of the new models, consistent with what Sharon was talking about, bundled payments, ACOs, even value-based purchasing, where home health providers are going to start getting dinged for 30-day readmissions from home health. So I just think that's another opportunity for finance, and it's sort of finance and partnership and collaboration, but it all is sort of related.
Do I have a second for that? Yeah, that's fantastic. Let's put that up. I want to turn what you said into under culture, encourage encourage debate or encourage this. Encourage. It's pretty good.
About a culture of innovation. I think that encompasses questioning the status quo.
If I can ask a question on that.
Yeah.
Because Joe's made an interesting point that I think is inherent to a culture of innovation is the concept of rapid prototyping, right? I mean, basically throwing stuff out there and seeing what works. But you don't necessarily have scientific proof that things are good and safe and viable and do anything when you're also pursuing rapid innovation. I guess as a question, I wouldn't know the answer to this, but how do you reconcile a desire to rapidly innovate and at the same time to have evidence-based safety and efficacy?
I have the answer to that.
Sounds good. I have a book contract for you.
Actually, the book's already been written. There's a clear distinction between research and performance improvement. And if you're working in an area where you're creating new knowledge, where there isn't evidence behind it yet, you're into research. If you've got evidence to support this, but it just hasn't been applied in this particular area, whatever, you can think of it as performance improvement. They share a lot of common traits, but there are some vital differences, particularly in the statistical analysis between the two. And I can send you the articles if you're interested.
Fabulous, actually. Yeah. Thank you.
Great. You can send it to us too. All right. So we're going to close this portion and we're going to move to the voting prioritization exercise. So you have 10 stickers, and I'm going to give you a little bit of guidance. I'd like you to attempt to put at least one vote in each of the 5 categories, but you have the other 5 stickers to do with what you like. And we will use this information to kind of bring it all together and hopefully come up with a list of things that we all feel are things that we can do. And you can, not all of these are apples to apples. So you have to kind of do your best with it. Consider how impactful it is versus how easy it is to do. If it's low-hanging fruit and you want to go that way, that's great. If it's something that you feel is so important, it's a little bigger lift, that's fine too. But this way we get a collective impression of the room. All right? So, please don't walk away. We're going to try to close this, and we're ending pretty soon. Okay, thank you.